And we're back for another video discussion of clinical toxicology. The subject this time is thyroid and antithyroid medications, corresponding to Chapter 53 in Goldfrank's Toxicologic Emergencies. The learning objectives are to be able to describe the expected signs and symptoms of thyroid supplement overdose and the time course in which this is expected, and to outline an approach to the patient with a thyroid supplement overdose in terms of identifying which patients need any intervention and what the pharmacologic therapy should be administered if they do. As you probably know, hypothyroidism is a very common medical condition. This is treated by giving supplemental exogenous thyroid hormone, so it makes sense that thyroid supplements are also common. And any drug that's found commonly might be expected to be involved in both unintentional and intentional overdose. The most common thyroid supplement is tetraiodothyronine, which is also called T4 since it's the T for thyroid hormone with 4 iodine atoms in it. The most common brand of T4 in the United States is Synthroid, which is called that because it's synthetic thyroid hormone. Since some people need more and some people need less, it comes in a range of doses from 25 to 300 micrograms, each with its own color. An older, not yet completely obsolete supplement is Armour Thyroid. This is the same Armour company that makes hot dogs and all other sorts of prepared meat products. And because they have a lot of animal carcasses for butchering, and there's a thyroid gland in the neck of each carcass, so why pass up the opportunity? Let's harvest those thyroids, dry them out or desiccate them, grind them up and put them in a pill. Before synthetic thyroid hormone was available, we were a lot more reliant on this product. You may have seen on the previous slide that Armour Thyroid had both T4 and T3 in it, because the thyroid normally produces both of these hormones, but it releases more T4 than T3. The T4 that's released, though, gets metabolized into T3, which is more active. Confusingly, both T4 and T3 have multiple names, as listed on this slide, which doesn't even include the drug trade names. There are T3-only thyroid hormone drugs available, but they're even less common. So for pretty much all practical purposes, if we're talking about thyroid hormone overdose, we're talking about T4 overdose. Because T4 needs to be metabolized, the toxicity from thyroxine overdose will be delayed. Typically, the toxic effects are delayed about 7 to 10 days, although shorter delays of only 1 to 3 days can occur with larger overdoses. It's been noted that pediatric thyroid ingestions are often benign, and I mean benign to the point of never developing any symptoms or symptoms so mild as to need no treatment. This is likely because most unsupervised, unintentional, exploratory pediatric ingestions are low dose, just a few pills. Adults, of course, might overdose on a wide range of pills and show a wide range of toxic effects, although with delayed onset. Right after the overdose, you wouldn't expect any signs or symptoms, and any lab tests you got would be unreliable in predicting the degree of toxicity that may occur later. A patient might have thyroid function study blood tests run after an exposure, and those results might help to confirm an ingestion, but they would rarely actually affect the treatment needed. The expected signs and symptoms of thyroid toxicity would include tachycardia, tachydysrhythmias, particularly atrial fibrillation or atrial flutter, CNS effects with anxiety and agitation, and potential for hyperthermia. Based on published experience, we can risk stratify patients by the amount ingested, which can help to guide initial management. As stated before, most kids do fine, with many not even developing any symptoms, such that if a poison control center gets a call about an ingestion below 4,000 micrograms, these patients are typically just monitored at home. Ingestions over 5,000 micrograms should get activated charcoal. Similarly, for adults, ingestions above 5,000 micrograms get charcoal, and if there is a massive T4 ingestion, which Goldfrank's defines as 10 to 50 milligrams, or 10,000 to 50,000 micrograms or higher, or the ingestion of a large amount of T3, which is expected to cause toxicity earlier, you might even consider gastric emptying in addition to charcoal and admitting these patients for observation. With such a massive ingestion, even if there is some delay, that delay should be shorter. Should a thyroid hormone overdose patient become symptomatic, what additional therapies would be indicated? Significant agitation should be treated with parenteral benzodiazepines or even barbiturates. Signs of catecholamine excess and cardiovascular symptoms, which typically means tachycardia and tachyarrhythmias, are treated with beta blockers. Propranolol is typically used here in doses of 1 to 2 milligrams IV every 10 to 15 minutes. Beta blockers have the added effects of also inhibiting conversion of T4 to T3. If a patient is hyperthermic, the chapter recommends active cooling measures rather than trying to rely on antipyretics. Antipyretics are directed at changing the hypothalamic thermostat, but that's not the problem with thyrotoxicosis. You should particularly avoid using aspirin since it competes with thyroid hormone for protein binding in the blood, which could elevate circulating free thyroid hormone levels. Some other considerations include the use of bile acid sequestrants and potassium iodide. So we've talked about thyroid supplement overdose, and here we are at the end, and we haven't even talked about antithyroid medication toxicity. And that's appropriate because it's so rare. Nothing more need be said. I'll be seeing you around.